Clare Wilkins is our next speaker. Clare is a former intravenous drug user and methadone patient who shed her chemical dependencies with the aid of Ibogaine in 2005. As the founder of Pangea Biomedics, she has facilitated over 600 treatments and has collaborated with MAPS to study the long-term effects of patients undergoing detoxification therapy with Ibogaine for opiates. She's currently working to develop a clinical trial for methadone patients using the cumulative administration method that she developed over 10 years of clinical practice in Mexico. As a member of INPUD, an international drug user rights organization, she's devoted to reducing stigma and harm, promoting the health of people who use drugs, and every human's basic right to medicine. Clare Wilkins.
Thank you. I can be heard. I'll place my beverage and the
clicker.
It's this, and okay, yep, all right. So my name is Clare Wilkins, and I'm director of Pangea Biomedics, which is an orthomolecular integrative center in Mexico, where we've been based for over 10 years. And we work with Ibogaine, and we work with vitamins, adaptogens, neurofeedback, a lot of different adjunct therapies. We were a part of the MAPS longitudinal study. When we started working, the conventional treatment structure and dosing protocol was you came in for a few days, you didn't really know the person. They showed up usually pretty unprepared, obsessed, frightened, mistrustful, and there were a lot of risks involved. And so when I entered the world of Ibogaine, which came from my own personal use, I took Ibogaine for a 9-year dependency for methadone, and I'm ever so grateful. And so this is what we stepped into, that Ibogaine has quite a lot of risks, and Paul Glue discussed this, and it always comes up as, ooh, that Ibogaine. You'll drink a lot of ayahuasca and take a lot of MDMA and mix ketamine and 5-MeO and that Ibogaine. And it's true. It's proarrhythmic. It's bradycardic. It induces a prolonged QT interval. It's hERG potassium channel blocking. And it's a cardiostimulant. Although it lowers your heart rate and lowers your blood pressure, it stimulates the heart a lot. And so we found when we entered the world of Ibogaine and created Pangea, and we had a staff of 12 in Tijuana, that we entered what I call, some of you will have seen aspects of this presentation before. There's parts that I wish to underscore and reiterate. But I call it the architecture of emergency. It was like triage. Like you didn't know what you were getting, you know? People would arrive and have all kinds of things hidden, and you barely knew them, and how fast can I get in? And that's it. It was like an emergency room is how I looked at it, you know? And the name of how we treat Ibogaine is a flood. That was like, well, we entered flood, and a flood's a natural disaster, like an earthquake, you know, tsunami. So and our demographic is as Howard, the discoverer of the anti addictive aspects of Ibogaine, said that we're 4 times as likely to die than the average person, when you're a regular drug user. And so these are what we were dealing with, is that we were dealing with people who weren't prepared, hadn't built therapeutic alliance, and were under a lot of stress with their dependency as well as their lack of preparation. And we saw a lot of emergencies. Roman Pasculin talked about this at the Vancouver conference in Gita in 2014, and has studied Ibogaine for over 10 years, and he's an MD in Slovenia. And Ibogaine increases energy in the entire body. And when you're already going through the energy of, drug dependency and leaving that behind, supposedly, you're also going through the energy of taking Ibogaine, which is, even if you're a normal human being, incredibly stressful. And so what we started doing was using Ibogaine as an adaptogen and using orthomolecular medicine and adjunct therapies. An adaptogen is a compound, a plant, something that results in homeostasis. And Roman was also someone who discovered this, that Ibogaine is an adaptogen at certain doses. It actually, you can calibrate it so that there's a sweet spot. You can take a smaller amount of Ibogaine and actually create a sense of balance with someone instead of really pushing them through something. And so we learn through this, our own therapies ourselves. We study it ourselves. So in the ICEERS, I'm going to talk about the ICEERS pilot study. We used adaptogens in the study, and I just wanted to mention that that's a real important aspect. It's not just like this is an Ibogaine study. I'd love to call ourselves we're a spirulina clinic, just to move ourselves away a little bit. And so, in the traditional context, in the Ombiri and with the Bwiti women, they increase doses of Ibogaine slowly over time. There's a historical context to this, low doses, and seeing what comes up in those low doses. How do you act with just a little bit? Do you get frustrated? Like, do you start already dreaming? What's going on? So with the pilot study with ICEERS in Spain, I'm just going to take a sip just to fortify here. We all decided to collaborate, ICEERS and Pangea, with someone who for 17 years had been on methadone without most people knowing. Work, her mother. Incredible. She attempted to stop, the methadone maintenance therapy, and we just couldn't sleep, and all kinds of the symptoms that arise from opioid, abstinence syndrome occurred for her. And so she would occasionally use a few things here and there, some joints, some drinks. When she had her own, when the treatment began, she didn't have any real, problems with legally or any psychiatric diagnoses, and she was real willing. And the whole team also was really enthused about coming together. I did this remotely via Skype, by the way, just a PS. So I would wake up at 3 a.m. when she went into withdrawal, and we would do this as they in the team in Spain were with the client, and we worked together through Skype, which is another unique aspect to this story. So I don't know, just for full disclosure. So the objective was, in Europe, it's not just you just switch over to short-acting opiates and then you're cool and we treat you like a heroin user or a Percocet user. And that's what is really encouraged in Mexico is, switch over to heroin, Percocet, find morphine, and it puts the onus on the patient to actually return to a place that they had removed themselves from for years. And so in Europe, it was very frowned upon to return to short-acting opiates. So this was a very important aspect of how we work. And how we work is through using Ibogaine and opiates together and pulling the cushion out slowly. And so it was a challenge to work with this in terms of making sure that we were being safe. Paul Blue talked about, like, we had measured, and it was we fought with not fought, but we pushed for the ECGs and all the vitals, and we measures, and I don't have any of those up because they're personal, and with the client, there's a lot of privacy that she's requested. I did not do it. They were there with her. It was a team, a pharmacologist, a medical doctor, numerous members of the team were present, a holotropic breath worker, so much support, an anthropologist who was studying as well as supporting. It was just, I really felt supportive and would not have been done unless there was an incredible amount of medical support, as Paul mentioned is important. So we studied all of this. I just want to mention, I'm going to go through it kind of quickly. It's like ows and sows and data. And so if anyone's interested in all of that, I'm willing to send the presentation to anyone and go through that. But essentially, we started watching as soon as Ibogaine was being administered, that the scores were going down. When withdrawal symptoms from methadone became physiologically evident, those are the OW scores. She took the first 150 milligrams of Ibogaine. 1 hour after Ibogaine administration, all withdrawal symptoms disappeared. SOWS 0 and reappeared 21 hours afterward. So a full day after, with only 150 milligrams, which is an incredible amount of medicine. 1 milligram per kilo. So it's really important to think about this. Like, are we looking for fireworks, or are we looking for safety? And are we looking for success? So through this process, we went through, the client was also working, by the way. Okay? She had certain times with vacation. We used that as much as we could. And she would take time over the weekends, and we would wait for her to go into withdrawal and then do the treatment. And there were quite a few challenges. She was, it was an incredible investment on everyone's part. So for 6 weeks, we administered medicine over increasing time. 1 milligram, 3 milligrams, 5 milligrams. We went through the milligrams per kilogram in order to increase the Ibogaine in her system over time. And as the Ibogaine increased over time, the decrease and desire for opioids went down. And she wanted to go fast. She wanted to go faster than the plan was. And it was our extreme, encouragement that she took her time to process, which she was very grateful for, because you don't just see fireworks, you don't see dead people necessarily. You dream more, you remember more, you sing more, you see more. And she started seeing this. This started happening for her. So although she was having these experiences that felt like nothing, quote unquote, was happening, it's like Ken Alper says, the most sacred aspect of Ibogaine is in its pharmacology. This woman is now almost 20 months free of methadone. And she wants to know, well, she wanted to say that how marvelous it feels to know that there's a feeling called marvelous. She returned to, you know, here's more the stuff, you know, we can chat about. I want to save time for questions. I see a lot of people in line for questions, and I like that. So we can discuss all this other stuff. But throughout the process, the ECGs were a consistent part of what we measured to show that it was safe what we were doing. We would never dose unless it was safe on all parts, and all team members agreed. So during this time, and also there were continued tests for not just for ECGs, but for her blood tests, which showed her liver enzymes going down, which is quite fascinating. So, yeah, the side effects. She suffered from sleep deprivation. She was glad to have those days of not taking Ibogaine so she could sleep, because she only used benzodiazepines at the beginning, and then realized she could use cannabis oil. In Spain, it's legal, and it goes wonderfully with Ibogaine, and it helps you sleep. And so for her, that's what she was using. It helped greatly. She also switched to some opium tincture rather than going from methadone. She used some opium tincture that she found legally in markets there, and was able to use those for a short period of time, which is like in the United States using poppy tea or pharmaceuticals, but natural. The plants, the full plant, and with under doctor's care. It was. I found it to be helpful. She found it to be helpful. So regarding the QTC, there were no clinically significant decrements. The heart rate did not drop with the 400 and 500 milligram doses to 53 blood beats per minute between 2 hours 2 and 3, a normal occurrence. At no point was the QTC raised above the safe clinical scores. The highest score of the QTC was reached with the 500 milligram dose at hour 3, being 444 milliseconds. So we found that we were able to maintain safe regions in doing this treatment. She also found time where she would be able to release her emotions and rest and integrate. And so we're going to talk about just finally the need for changes. You're going to let me know in 15 minutes? It'll go yellow. I got 5 minutes? I have 15? Really? Wow, cool. The need for changes. Incomplete treatments. We used to work with 80 to 100 people per year. We now work with about 20 to 30. We decided to focus on one person at a time, or a pair at a time, or a family at a time. We found that, immediately upon doing so, our success rate improved dramatically. We found that, we found problems where the onus was placed upon the client for so much. You have to find your short-acting opiates. You got to switch from buprenorphine to something. You got to get to Mexico. You got to get a passport. There were so many obstacles placed on people just attempting to be free neurochemically. When I asked Howard Lotsoff at the 2009 conference where we honored him, he and Boaz Wachtel and I were hanging out, and we were just chatting, and I said, so Howard, what do you want to see, in the next year? What would you like to see happening? And, I thought, oh, maybe a cruise or, I don't know what I thought, something like that. And he goes, clinical trials. It's like, okay, yeah, I'll get right on that. Okay, great. Okay, so we're looking at long-term studies, the longitudinal studies that are happening. ICERS has received ethics committee approval, MAPS. Kingsley is about to be published. Jeff and Kingsley are going to present on their data this afternoon, which is going to be fantastic. And so what we want to do is create larger samples and design protocols that can be integrated into what already exists, rather than be this fringe kind of outcast from the, other planet. The transitions, we've learned that, what I've just talked about, repeated doses require active participation, enhancing neural networks, extending the treatment duration. For 6 weeks, we worked over this. Now, time-wise, money-wise, you're going to ask, how did that happen? How did you do that? We all volunteered. The ICERS team, the client, I did, we all volunteered our time. And this is, in the name of science. And I believe that we may even be published. An article has been written, and we may be published in the Journal of Psychedelic Science. Right? Borja? Yeah. So, learning the language of Iboga, cultivating friendship and compassion with the mind. In a week? Are you going to do that? Do you do that with a human being? Sometimes, So with Iboga, there's a lot going on, a lot of layers. The family, the treatment environment, and incorporating the clinical and the natural, we found to be the most efficacious. We did the whole medical model thing. We've done the jungle thing, and there's a combination of making sure that you utilize what nature. This plant has existed in the center of the earth for millennia, and it's for us to learn from it. And I feel honored that this room is full. It just astounds me. So, even after all this time, the sun never says to the earth, "You owe me." Look what happens with a love like that. It lights up the whole sky. That's how I feel. I want to thank you to the courageous ICERS team for collaborating with Penji on this wonderful study. Dr. Jose Carlos Boschó, Bendelonen, Doctora Estefania Morena, Pep Cura, Mark de Aishala, and Oscar Perez, and all the angels that made this happen somehow. So we can go to questions.
Claire, do you want to have some of the other presenters take questions too, or do you want to take them just by yourself?
I'm open to anything that.
Let's see who we've got.
Yeah, let's see what we got. Yeah, let's use the time up. I mean, we're all up here together. Yeah. Let's do that.
Go.
So, yeah.
My main question is regarding, you said there was an overall decrease in withdrawals and stuff, but did you measure or take into account or notice any changes in symptoms of post-acute withdrawal?
Yes, we did. And what we did, we used supplemental small doses. And it's mentioned in the treatment section. And there are vitaminic doses that we use where she was able to actually take certain amounts and go to work. Now, the topic of microdosing has come up a lot. And I want to be clear that microdosing is, as James Fetterman says, when you don't feel it. Okay? And so, there's that thing where you want to attend to what you're dealing with and then also, feel the motivation from the medicine. With post-acute withdrawal symptoms, that's why we have so many adjunct therapies. That's why we work with so few people, so we stay in touch and we're adjusting protocols and orthomolecular protocols, amino acids, exercises, therapies, who connects with who, etc.
That was a great talk. Thank you.
Oh, thank you.
For these lower doses, do you see applications beyond opiate addiction? And also, I was wondering if you could expand on the lack of sleep. Is that pretty common, even at these very lower doses, while they're on it, that they won't be
Well, the
sleeping?
doses accumulate. So I forgot to mention that what we do is we saturate the body. So it's instead of flooding, we saturate. So there's a point people reach where it's like you're glowing and you're looking just like someone does who's had medicine over just a few days. It's just taken 3 days for some, or 7 or 10 days for others. And yes, even if whether you're chemically dependent or not, one of the side effects of Ibogaine is it wakes you up. It wakes you up. That's what it does. It shows us what we do not want to see. And that's a big part of waking up, right?
Are you seeing potential for this method beyond opiate addiction?
Yes.
For other types of
Yes. Thanks for saying that. I do. We have different protocols for depression, for antipsychotics. We have numerous protocols, and what we really want to do is collaborate with people and share, this work that we've spent this time just working on bit by bit and connecting with people. And I really hope we have an Iboga safety forum tomorrow that we invite everyone here to. Please, it's at 9 a.m. I know people will be crunchy and, but I still invite us all because it'd be great. So yeah, there are a lot of applications that I see, but I'm not I don't lean towards the evangelical or pushing people toward Iboga.
Okay, hi, I'm a psychiatrist practicing functional medicine and particularly using an orthomolecular approach to addiction. And I've thought throughout this whole conference that it's a wonderful adjunct to all the plant medicines and all the psychedelic treatments. And you're the first person I've actually heard speak about it, and I'm really excited to hear that because there really is a common ground here.
Yeah.
So I'd love to hear more about the orthomolecular aspects of your program.
It's the spectrum of the plants. Spectrum of the plants and the proteins.
You mentioned something about amino acids, vitamins, and so on, not just the plants themselves, but it sounded like you were talking about additional nutritional supplements.
Oh, yeah. Oh, yeah. We go through to great lengths to acquire our products, especially in Mexico. Traveling to the United States and such.
I still don't quite understand what your protocols are for orthomolecular and how they're woven
If you want,
but could I find out?
I'll be available and we
Great.
can exchange emails and go
Wonderful.
over it, and I'll be open to share and
Great, thank you.
Yeah, for sure.
Claire and Paul, thanks very much. Really, really great presentations. And I guess, Paul, a question for you.
Stand up.
what I'm seeing, I guess we're seeing here to some extent, is like these sort of ideas of treatment seem to be converging. You know, from what Claire's described and your own experiences, what you've been doing, what possibilities do you see? Your question was, you know, how safe is Ibogaine? I guess what I'd like to extend is like how viable are we? Are we moving closer to a viable treatment? Do you see with what you're hearing from Claire and the kinds of practices that we've heard described, that we are actually moving to bring it out from the shadows, as Bruno suggested? Are we looking at a viable process here?
Thanks, Jeff. It's a very simple question, but it has a lot of components to it. So one is what's the risk benefit of using this drug? And clearly, being on opiates, being on crack cocaine, whatever, has risks in an untreated environment. And they're clearly greater risks than one might get if you're, say, treating someone's hay fever. You've got to have a perfectly safe drug for that. I think you can build in a little bit of risk in a drug that's being used for a much more complicated, potentially lethal condition. And so the safety things I'm talking about are not killers. They certainly have an impact on how you might dose people, how you might manage people, how you might design clinical trials. In terms of where the next steps are, I think the wonderful story you told about Howard Lotsoff saying, we need clinical trials, is where I think things have to go. That without being able to show, yes, this separates from a placebo condition, we're dosing it under these conditions. It may not be the best way possible, but at least you have a viable protocol. I think are really key elements. I understand that there's a lot of other, say, spirituality, orthomolecular elements. I'm a very conventional, medically trained psychiatrist, so I would have great difficulty on commenting on those things. But I think there are some really basic safety, pharmacokinetic, clinical trial data that could really bring Ibogaine along as an effective treatment and potentially get it approved by a number of regulatory agencies.
Would Ibogaine or any of the other plant medicines be helpful for people with autism? Anyone who can answer.
Sorry,
Yeah.
this isn't my area of expertise, but I'm not aware of any literature.
Yeah, the literature is small. There's not much. It's anecdotal. It's hard to say. Ibogaine is a heart-opening medicine for a lot of people, and autism is a very complex set of properties and neurodiversity, and just like with addiction, and it's a hard one to touch on. Yeah.
There was an interesting presentation on the use of MDMA to treat social anxiety in autistic adults being presented this morning.
Yeah.
But in terms of Ibogaine use, I think that's yet another thing in the to-do column.
Thank you so much for being here, both of you. Claire, I have to give you a hug. I don't usually hug the presenters, but I'm going to make an exception.
Thanks so much.
Heroic work.
Take this.
We're going to take a little break.
Okay.
I have a couple of announcements before that. Sleeping is permitted in the guest rooms only. Thank you for respecting the common area guidelines. The Skyline Room, that's us, on the 21st floor, is a chill space from midnight to 6 a.m. tonight. Soft music in the company of friends.
Make sure my
And the music celebration in the West Hall has been extended to 2 a.m. tonight. Come dance and enjoy. We'll see you back here in about half an hour.